Okay, let's get going here. Welcome to Project Echo. Today we've got John and Todd doing a talk on addressing patients with complex pharmacology and multiple medical diagnoses. Get through my quick housekeeping stuff here, then we'll get through the experts for the day. This slide here just says that those involved in this project have no financial relationships to disclose. Funding statement funded by the federal SOR grant that comes to us by way of Nebraska Diagnoses. Usual process for CME certificates, you'll get a link to a survey at the end of this training. That'll come to an email this morning. There'll also be a link in the chat. If you're looking for the survey in your email and you don't see it by the end of the morning, check your junk mail. It seems like a few people every training, it ends up in the junk mail. And as always, if you have any questions, my email's here. You've probably been receiving emails from me, so you can always reach out and contact me. Just a reminder where we are in our current series here. This is the third of 4 trainings that we've got going. After this, we'll be off in June, and then we'll be back for another 4 trainings in July and August. And I'm going to turn it over to our experts here for introductions here. So I'll just go on my screen here. Gail, it looks like you're first.
I'm Gail Keller. I'm a nurse practitioner down in Falls City.
And Ed.
Hey, good morning, everybody. Again, Ed Kaiser, nurse practitioner, Omaha, Nebraska. Been working in the substance use disorder kind of addiction field for the last 6 years. Glad you all are here.
Stephanie.
Stephanie Bennington, psychiatrist, primarily located in Omaha. Nice to see everyone.
And then I think Todd, I'll let you go next.
Good morning, Todd Stahl. So remember that these can be used for your renewal for your DEA and the CME for that. So if you're needing, when it's time to renew and you need your waiver, this is considered the waiver. There's no longer an X waiver. So this is a part of that process. So please do claim your CME because it is free from this and your perspective, but you will need it to renew the DEA. So I'm a psychiatrist. Good morning and thanks for joining.
And we're missing, I don't see Janet Bernard on here. We're missing her today. So we'll just turn over to you, John, and I think you're going to run the PowerPoint.
All right. Good morning. Hi, everybody. Today, Todd and I are going to be talking about, we're trying to really wrap up what we've been talking about for the last few weeks. And we're going to kind of be talking about those difficult patients and the complex cases that we're trying to make this a practical discussion about some of those challenging things that we see. And you remember from previous parts of the series and prior series that really what we know about the clinical aspects of this problem is that in pain, especially the overlap between chronic pain and substance use disorders and mental health disorders is a very widely overlapping Venn diagram. And we've talked on multiple occasions about how much that impacts our clinical decision making and how we need to take that into consideration. And today we're going to just kind of walk through some practical aspects of that. One of the statistics that's always interesting to me is that something like 90% of the total MME prescribed for opioids in the United States is for 5% of patients, as one of the very concerning factors. And also that those 5% of patients tend to be exactly the demographic that we would have concerns with respect to mental health disorders and or mood disorders. So it's incumbent on us to kind of rethink how we manage those difficult patients that with overlapping disease states so that we're improving each one together and we're not thinking of these various conditions and the care for these conditions as competing with each other. So Todd, would you say that's a synopsis of what we're going to go over today?
Yeah, I think it is. Let me add just a few things to it. So, when this whole thing started with buprenorphine and the what was called the data waiver way back in 2000 when it came out and then approved in 2002, the notion was around addiction and substance use disorders. And over time, what's evolved and the reality is that, yes, there are clearly people that have substance use disorders, and half of them will have a mental illness. But what we really what was overlooked during that was the number of people that had pain. There are way more people that suffer from chronic pain than addiction problems in our country. And so the three overlap, as John has said, but leaving that group out, what was found is that kind of unmanaged or unaddressed pain led to problematic issues with further substance-related problems and mental illness. And so pain has been included in, which is terrific, finally, right? And the other point I want to make, besides the number of people that have not only acute, but especially chronic, ongoing, debilitating pain, and you've heard us say this, many of the opiates by themselves are not overly effective for that sort of thing. And so there's a little bit different kind of binding when it comes to buprenorphine. The final point I want to make that ties everything together that John has already said is these pathways and signaling processes basically use the same kind of neural circuitry when it comes to pain and mental illness and substance problems. So they're intertwined, kind of like wires wrapping around each other to think about that in what are called these salience networks within our nervous system. And so it's very important that when we're trying to present, we're addressing all three because often they're so closely related. So that's all I really wanted to say, but I do want to emphasize the connection between the three.
So long and short of it is we're making each of these conditions better with appropriate care, or we're not making progress if we're not treating each one together. And so that's probably the moral of what we're trying to get at. So let's kind of go through let's just start out. I'm going to share my screen here and see if I can find my way into the PowerPoint. Oh, it's always a challenge. Hold on a moment. Gonna view show first. All right, see if I can get this to share correctly. Sorry. Are you seeing?
There
Nope.
we go.
Now it's coming up.
There we go. All right. How's that? You got a patient at least finally?
Yep.
All right. So let's start with this first patient, and a nice way to keep in mind what keep in mind our Venn diagram. All right. And this is a gentleman, a 36-year-old truck driver, CDL truck driver involved in a crash of his truck on the interstate, taken with trauma eventually to trauma center, where they found that he had a C7 transverse process fracture, rotator cuff tear, probably two maybe three rib fractures. And since it was a motor vehicle accident, since he was a commercial driver, they did a routine urine screen on admit. Unfortunately, they found cocaine, methamphetamine, several different opioid analogs in his urine drug screen, and he received care, stabilized, just got conservative care, and after being discharged was referred into our clinic for management. So the question is, what are we going to do about this individual, and how are we going to make some progress on that? And the best part of this, I think, as a case would be to kind of see if people want to ask questions about that, or if they wanted to kind of consider the three elements of what we're talking about. So Todd, would you like to ask questions, or would you like to see if we could get our crew to ask us questions about this?
Let's see if individuals will ask questions first, and if not, then I will.
All right.
So if you're approaching this patient, what kinds of things would come to mind?
I'm having a hard time hearing.
I think that might have been an accidental unmute.
Oh, okay.
Possibly.
I was
Um,
hopeful we had. I was hopeful we have someone. So-
You're free to unmute, or you can throw the thoughts in the chat, and I can read those. Yeah.
So fundamentally, we've got, if we want to just break this down into our three buckets, right? We've got somebody who has now acute nociceptive pain, right? There's trauma, there's tissue injury, there's a transverse process fracture, which is painful, kind of meaningless neurologically, but it's going to be painful for a bit. Certainly rib fractures will be as well. And yet we've got an individual who has evidence, certainly on the chart of misuse of medications in a very risky fashion with a resultant injury and damage, and a prior history of some sort of treatment for mental health disorder despite their situation. So how do we break this down? How do we manage this individual, and what should be our thought process on that?
So we got thought in the chat from Jean. She says, how to manage acute pain in the setting of SUD.
Yeah.
And then Clinton had a comment, UDS was positive for all of those things.
Yeah, that is true. This is an actual case, by the way, too. Yeah. So certainly we've got misuse, right? We've got misuse of illicit substances, stimulants, not uncommon in individuals who have to be up a lot, working late hours. Certainly somebody with a CDL is not going to present like this very frequently because of the need for ongoing, urine drug screens and what have you in that industry. But fundamentally, we've got tissue injury. We've got somebody who's had an injury. We don't have to get into how specifically what we could do that would be non-medication for managing this acute pain that's occurring. But how would we rank in our mind what's most prescient in terms of what do we need to get better first in order to facilitate improvement in all three areas? And that's kind of, I think, to me, that's the big question here. How do we order what we're going to do in order to get some progress clinically for this patient?
A couple more comments in the chat here. Joyce asked, is he going through withdrawal from the above at the same time? And then Kelly Field says, treat pain at the same time of dealing with misuse, but cannot cure addiction yet. Acute pain treatment first.
Okay. That Kelly makes a good point. Todd, do you have thoughts?
Yeah, so I mean, in terms of, I like the progress and the progression of what we're doing here is what do we need to address immediately first, right? And given the presentation, and then gathering additional history as the acute component kind of is addressed, and additional history would include things around things in my mind, and question to ask, does there, when you look at the thinking process, does he have previous kind of problems with pain? Does this 36-year-old have previous problems with pain, given that he's had hydrocodone before, and he's been on 2 SSRIs before? What's his kind of pain history, previous substance history, and previous mental health history? So could you elaborate on that? And in the context of, gee, what do we do initially though with the pain?
Great point. So first, one of the big problems is this guy's going to be guarded, right? It's going to be really difficult to get this guy to tell us a story about what's really been going on. But fundamentally, he's had a long-standing history. He's a larger individual. He has a history of type 2 diabetes and peripheral neuropathy. So he's had had somebody trying to manage his peripheral neuropathy in the feet with hydrocodone. A little bit of success, not a lot of success. He was relatively uncomfortable prior to the accident from that by his report, but certainly somebody, he did have a history of getting some treatment for chronic pain, and we could, we talked about this in other meetings. Hydrocodone is really a terrible choice for neuropathy. Neurogenic pain doesn't respond to opioids, but it's certainly not something that would be unexpected for somebody to try as a means to get some initial improvement. He didn't have any known history of misuse of substances prior to this, and he's on presentation. What was also interesting is he was guarded to the extent that he was accusing the hospital of fabricating his urine drug screen because he said he claimed somebody had stolen money from his wallet while he was in the emergency department. So there's obviously a challenge with the history of this individual. We're not going to get the full story, and that may be a reflection of his, medical legal status because of the injury, obviously, but it might also be a pre-existing level of denial with respect to misuse of medications. To me, when I see this patient, when we saw the patient, that the thing we're looking for is any level of insight. We've got to find some way to communicate with this guy that, we're here to try to make this better clinically, but we need to know really what's going on. And when he put up that wall, that's going to be a big discussion point, and it's going to be challenging. We're not going to be able to use our typical motivational interviewing skills to get to the bottom of the story, because he's going to protect himself from what he feels like is, risk associated with the circumstances of his injury. But the thing that's going to be interesting clinically, and Kelly, you make a great point, we're going to treat acute pain. You have to treat acute pain successfully to get this individual better. And that to me is where the rubber meets the road on this individual, because an individual who maybe he was misusing stimulants, or he was misusing stimulants, maybe he was developing a substance use disorder with that, but we didn't really have any evidence that he was having opioid use disorder prior to the accident, right? He was using some hydrocodone for neuropathy, and he was generally taking it as prescribed, so he was managing it. So what we would typically see in a situation like this, you could go in either direction. You could, in the emergency department or in the acute phase, you could increase your opioid prescribing with legacy opioids. If he tolerated that, he's not going to be working. And you could see how he responds. And he's going to respond in one of two ways. He's going to either kind of respond to it and get better. That's what had happened. He had been given oxycodone, and he was given 10 milligrams of oxycodone QID, and he did better for a couple weeks and was making some improvement clinically with respect to the acute pain. It turned around and he got worse after about 2 weeks, and he started to escalate with the medications, and we had to go in a different direction. But we kind of used that as a test to say, what are we going to do in the short phase versus what are we going to do in the long phase?
Let's say he came in intoxicated, and that was in essence the cause of the accident. He was impaired from the combination of medicines he's on, including he's sluggish and maybe in a somewhat of a delirious state because of too much of a opiate. What would you do then? And there's several questions in the chat here too.
Okay, I should be reading the chat. Well, so if we had evidence of impairment and he was intoxicated and still using, that's a situation where now we would, in my mind, we would jump the treatment for the use disorder to the very top of the list. In other words, if somebody's continuing to use and becoming impaired and not functioning, and we've already seen the evidence of the injury as a result of this, that's when the only rational way to proceed is to make immediate efforts to stabilize the use disorder to the degree that we can as a predecessor to getting improvement with the other parts of his condition. So this is where it's important to kind of understand, remember our data about buprenorphine, even in an acute pain setting, it's equally potent, if not increased potency for individuals compared to legacy opioids. So there'd be a different reason and a different speed with which we'd want to switch that guy into buprenorphine therapy. Does that does that thinking pattern make sense based on what we were talking about in previous discussions?
So the other thing to think about here is that if somebody has a opioid use disorder, he's using fentanyl and oxycodone, even if it's for chronic pain, and then they develop an OUD, and they're trying to do stay awake, it's not uncommon to use stimulants. In a urine drug screen, cocaine is cocaine. And whether you've bought it off the street or you have it's been used in a medical procedure, that's done, but not very often. There's some things that can look like methamphetamine, but the idea in this case is both are stimulants. And so though it wouldn't be uncommon, and I don't know if he mentioned this, that he does this gentleman have ongoing kind of pain? Is there an OUD prior to this accident? And then was he using the stimulants to, in essence, offset this sedating or impairment that can be created by opiates?
Yep, exactly. And another way that we can think of that is you don't really have to make a decision whether you prescribe or not based on all of this. One way you could just say is, we're going to go in one direction and see how it goes. So in the acute inpatient setting, if this individual had a PCA started or had oral opioids at a higher MME started and he responded, then that's giving you evidence in one direction. However, if you're going up on the medication and somebody's like, we're continually getting calls, he's not doing well, that by itself is evidence of hyperalgesia and use disorder, and that would drive us to switch. So the concept of switching into buprenorphine is different than just deprescribing, is what we're trying to say with that. Does that make sense?
The other thing you may want to think about in a setting like this, remember somebody's a over-the-road trucker. They are routinely have random drug screens. And so I know this because I serve as an MRO for drug screens for for occupational health. And there is a market deterrent built into those kinds of jobs for someone to use a substance that's prohibited. Those substances in this case could easily be the opiates, and clearly are, if it's the D-isomer of methamphetamine after the chiral separation test, and it is methamphetamine and it is cocaine, and he's using those, that not only is pretty risky, and all those drivers are aware of it, but that's not something you can solely hang your hat on, but a pretty clear indicator that you need to probe further to see the extent of, does this individual have a substance problem? And it's not very common for a trucker or somebody that's going to be monitored in the Department of Transportation for drug screens to use especially coke and meth. And so those things are pretty important. Did you learn anything from that aspect, or did he reveal anything from that aspect, John?
He really remained guarded throughout our care. And we'd never really got down to the real story. And I think we just eventually hung our hat on, use of these medications despite clear evidence of harm and risk, and kind of the lack of the patient-physician relationship. So we switched into buprenorphine therapy and got some stability is where we went. So let's go to another case here, shall we? Is that all right, everybody? this is a different case and different presentation, probably one that's more common in a lot of situations for everyone here. But basically, we've got a 71-year-old gentleman who's had a history of multiple spine surgeries. He's had fusions that have eventually been extended from L2 all the way to S1, just step by step. He's got a real sagittal imbalance. He leans forward. He's osteoporotic as well, and a wide variety of diagnoses in his chart that even predate some of his lumbar spine injury, including history of, he's firmly believing in his concept of fibromyalgia because he's had widespread pain for a number of years, and he's got a diagnosis of depression and anxiety that probably has not been fully separated out with respect to the fibromyalgia. But he also has GERD, obstructive sleep apnea, and his body habitus with his forward-leaning posture and kyphosis certainly probably represents additional challenges with respect to pulmonary function. He comes to us from out of state, just south, and he's in Kansas. And on our first visit, he's on 120 milligrams a day of morphine. He's taking oxycodone 5-6 times a day. He's on Savella. He takes Xanax 3 times a day, nortriptyline, Neurontin, QID, as well as muscle relaxant. He's had enough pain care in his prior provider's office to get a neurostimulator that he believes is somewhat helpful. Not fully sure how much, but he's one of those individuals that gets to our doorstep with just enough medication to get through the week. And I need help. I've got enough here. Basically, tag, you're it. So what are the questions we want to ask, and what would be the approach we'd want to think about with respect to our overlapping Venn diagram? For chats.
While we're waiting for questions to come in, I'll pose one. What's the impression you get of what's the most important thing for this patient, or the thing that bothers him the most?
Well, he frankly, the presentation is a little bit desperate. It took him a couple of weeks to get into our office, and he has already gotten that, 1 extra month of medicine to get to us. And he doesn't know exactly why his prior physician can't or won't prescribe for him. So his primary concern on initial presentation is, I just need my medicine. I have to have my medicine. I wasn't doing great. I need help, but I have to get my medicine or I'm in real trouble and nobody will help me. And that was kind of the overriding presentation we had. He and his wife are both there, kind of, you got to help us because we're stuck and we're not in a good spot.
Couple of comments in the chat. Joyce would want to ask the patient why the previous MD stopped prescribing to him. You have to talk to the physician about that. Clinton says he needs buprenorphine. Nicole wants to ask, how are your current medications falling short in terms of treatment of current pain? And then the last one so far, Henry is asking, how is he sleeping? Is he using a CPAP? When was his last sleep study?
Okay, so yeah, good questions. So really, I think we're catching on to the idea that what's going on isn't helpful. He's got risk. He's got the OSA, probably certainly at higher risk of problematic or complications with that level of MME. But I'm going to remind us of a couple features with respect to the CDC guidelines, right? Because we're here in part because of the CDC guidelines. We can't find out why the prior prescriber isn't going to prescribe for him. Let's say we we'll just imagine the worst. Let's say this clinician in Kansas, you know, is in trouble or lost their license because they are managing a number of patients in a way that was maybe problematic. What would the CDC tell us about what should be done for that patient is counterintuitive to some of us. Remind ourselves that the CDC specifically says that under these circumstances, you should not forcefully deprescribe a patient. All right. And that is oftentimes, right, the first thing we all see, we've been in this long enough that we're thinking, all right, let's get this guy to buprenorphine ASAP. But the first thing we should keep in mind is that the recommendations and the way to know, you know, how to stay within guidelines is to not say, hi, Mr. Jones, you know, I'm not going to prescribe for you. This is dangerous. We don't want to combine these medications. You're on too much. You've got all this. I don't know what the other guy was thinking. Therefore, I will wean you down. That is exactly probably what the CDC says not to do, because this individual will be at increased risk of morbidity and mortality if we did that, even though we know that's not what we want to continue, right? So I think that's a point that might help us to it gives us a little bit of a way to manage this with more of a patient-centered approach, motivational interviewing, and use that kind of bit of this to help us. Let's get back to the concept of the three aspects of this. So we've got evidence that this guy is certainly anxious, right? He's definitely anxious about his medications and focused on his medications. He has a history of these 3 diagnoses: fibromyalgia, anxiety, and depression, which are kind of, you know, is the fibromyalgia real or is it just somatic depression? We don't know. But certainly there's a longstanding history of a mood disorder that we would expect to follow with chronic pain. And he also has kind of the holy trinity of what we don't want to be doing with prescribing, right? Muscle relaxants, sedatives, benzodiazepines, and excessive amounts of opioids, despite, you know, not doing well. So he has evidence of all 3. Where do we take this patient in order to move him forward? Any other?
Let's see, we've got a few other comments in chat. I can read through those. Gene says, red flag for OUD plus multiple sedating medications in an older adult with OSA seems like buprenorphine is the right choice.
Yeah.
Clinton says, which of his meds do you continue? Does he have a CPAP? Joyce says he's a suicide risk due to age and psychiatric issues in him.
Yeah, exactly. All those comments are right on the money. He does not have a CPAP, had not had a sleep study, and not sure if anyone ever presented that to him or why he hadn't, but he just didn't. His functional status was not terrible, despite the fact that he's forward bending all the time and he has a difficult time, you know, walking as a result. But here's what we did, and so fundamentally, to me, this is a good chance to say, here's an individual who's taking his medications as prescribed, although as prescribed is silly, if not terrible, right? And so to me, this was the chance where we could use our ability to build a relationship with the patient, develop that therapeutic alliance, sort of say, hey, you know, we understand that this medication is the only thing that's keeping you going, but how about I have a better way? Let's talk about how we can move to something more effective. And I know that makes you anxious, so let's wait to do that, but I want to start that conversation today. So I think that in this situation, the important thing is to prescribe this medication for this patient so you're not leveraging him in any way. You're not saying my way or the highway. You're not saying if you want to stay in my clinic, we're gonna have to make a switch. You're saying, I know this isn't in your best interest, but I can do better for you. And what's better is going to be a switch that you might be nervous about, or obviously you will be nervous about, but let's open that discussion. So I think in this situation, that's really critically important because you're going to make everything else so bad if you don't, with respect to the anxiety and the risk of him going off and doing something, or even suicidality and what have you. So we said we're going to prescribe for you in the short run because it's not your fault that you ran out of, that your medications are there, but we're going to be making a change in the future. And I want you to come back to my visit in a month or in 2 weeks. And I want you and your wife to have written down a specific set of questions about what it is we're talking about and what you see as the challenges to wanting to move in this direction. And let's go over that. And that's kind of how we proceeded under this set of circumstances. And then, interestingly, what we did is we saw him back in a couple weeks. We wanted to be sure that we were watching his use pattern, making sure he had control of the use of these medications. And they came in and they were pleasant. They were listening, but they had a lot of, they really had a hard time with this. They were very anxious. Do you know how long I've hurt? Have you looked at my images? Do you understand that, if I miss a dose, I can't X, Y, Z. So they were really kind of semi-confrontational at that point. They had a chance to kind of develop a strategy about what were they going to be able to do that would convince me that their current regimen was good. And I recognized that as a challenge moving forward. It was basically, despite what I thought of as, my best motivational intervening attempt, I hadn't gotten there. So we prescribed for another month for this individual. And anyone who knows my practice, I'm not a Xanax, morphine, oxycodone, cyclobenzaprine kind of prescriber, but we did do that for an additional month, just because had we not done that, the chance of this going south and not going well was pretty great. And I guess the teaching point on that I think is important for us is to say, when you're in a spot, because we've all inherited a patient that we don't want to take care of, or we don't agree with what's going on, it does make sense to say, hey, this is a legacy patient that's been prescribed in a fashion that may not be in their best interest. I'm going to continue that for a brief period of time in order to build the patient's acceptance of my future medical plan. And I think that's very sound medical care. And I think it's supported by the data and certainly the recommendations. As long as what we're doing is making a real effort to move the patient in a different direction, we're actually reducing risk by doing that in the short term. And I think that's a subtle point towards moving in a better direction for patients and keeping them with us. Comments? Questions?
So we had one question from Brent. How confident are you that you can know what all he is getting since he's from out of state? Perhaps another provider still giving him something.
Yeah. That's a great point, right? We're not at a place where the PDMP can help us in this situation. Yeah. I didn't even intend to put that in the discussion point, but that's an excellent point. So I really wasn't confident. What I was able to do was to watch with that 6 week period of prescribing in that fashion to see how he was using it and what was going on, and see if he was moving towards a better direction. Next question I'd ask the group, how would you, he did get to the point where he's like, I don't know about it, but I guess we're going to do it. We'll give it a go and see how it goes. Now, how am I best going to switch this individual into a better regimen? What would be your strategy to change the direction so he has better pain relief and or better safety? Any thoughts on that? Oops. Well, early in the day. So this was an individual that we did the microdose induction on, right? He was a great candidate for microdose induction. There wasn't use disorder. I didn't have to emergently switch him over, and he was very, very anxious. And so what we did is we did a very prolonged microdose induction of buprenorphine. We took 2 weeks to get him there. And the key part of that was that I switched him over in a fashion that let him pick the rate at which he decreased his legacy opioids. Now, uncomfortable part about that was the way we did that was I removed the morphine, extended release morphine, which is, as you can see, 120 MME, and I had to replace that with oxycodone. I had to give him a bump up in his oxycodone for a few days so that he didn't go into withdrawal as that buprenorphine was building up. I said, you can go up to 8 times a day on your oxycodone initially while that buprenorphine is building. And it took him 10 days to do the switch. But we took that approach and it was very effective for him.
As you think about this individual, and the other thing that would be of consideration is clarifying from him if it's possible for him or his wife to say which of these have made a difference for you, and how do you know? In other words, getting that information, because the ones that are less clear may be the starting point to a degree for eliminating. Plus, you've got duplication of mechanism of action here with some of the medications. And so it's very reasonable for an individual that's on this number of medicines, when you're thinking about switching to buprenorphine, for you to be able to eliminate a number of the medications that he's taking, all the way from cyclobenzaprine. Remember, our muscle relaxants, first and foremost, have a central analgesic effect and less so peripheral, and that's often overlooked. Neurontin, is taking a look at kind of the, has it been effective? Is it really being used for anxiety? Obviously, looking at alprazolam, remember, if this gentleman falls and gets a hip fracture, which he's at high risk for, the outcomes are not good for those individuals. And so when you talk about a serotonin norepinephrine reuptake inhibitor with Savilla and Pamela or nortriptyline, both, you're talking about treatment of potentially both fibromyalgia, both a neuropathy, chronic pain. And so do you really need both? Is there benefit? How much benefit has there been with either for depression or anxiety? And then if you're switching to buprenorphine, remember you've got kappa antagonism, which has effects on mood. And so it's not uncommon for individuals to notice an improvement with their mood solely due to buprenorphine. And so, I think over time, there's a sequential gradual progression of not pulling the rug out, but thoughtful dose reduction at strategic points with one medicine, and progressing as you adjust the microdosing into now more therapeutic dosing of the buprenorphine.
Excellent. The interesting part about this switch is what we did take that approach to a degree, and kind of watched all along at his level of participation. One of the things we were able to do pretty quickly was switch out the alprazolam for clonazepam as a way to try to sort of back that down initially. And he was really able to participate in that very effectively, and it helped him develop some confidence that this was going to be possible. And this is a point to really emphasize, is when he came back 2 weeks later, his comments were twofold. One, I thought I was going to hurt more and I hurt less. I feel a lot better. My wife says I'm more like myself. I've got more energy. And third, but over the course of the last 7 or 8 days, or 8 or 10 days, I did have some bumps in the road. And he described them. He had some nausea. He had some times when he was overly sedated with the medication, he thought, and then he had some times where he was describing things that were a little bit like withdrawal. And so what you're seeing is this was an individual that was developing problems both with a little too quick and a little too slow of the transition from his legacy medications into what we were moving. But since he had been to my office, we had talked through it, and he understood that he was, and probably most importantly, he was being allowed to pick the rate at which he switched. He tolerated it. He understood where he was going, and he didn't increase his anxiety. So we really thought of it as a win, and And now he's on 16 milligrams a day of buprenorphine, and he's happy as can be. And he's had about a 70% reduction in his pain, which is better than we were able to do, with he'd been able to get with anything in the past. So it really, even with these kind of daunting patients, this is something that really can be done. And if you just take that approach, it can be functional. Should we move to the last one and see if we can get through one more?
While you're
So-
moving to that, John, let me so there's a quick question about anxiety and depression and so on, is civilomanalciferin, which is a serotonin norepinephrine reuptake inhibitor that goes through phase 2 metabolism. So it has lower drug interactions than some of the other SNRIs. SNRIs are things like Effexor, which is venlafaxine, duloxetine, which is Cymbalta, and so on. All have kind of benefits in the same capacity to look at pain. All should have similar benefits. Individually, they may be different, similar benefits for anxiety and depression. And so the issue is, does this individual respond to it? One, and what happens with the mood on buprenorphine? Does he even need that? And then looking at removing potentially the nortriptyline. If you've got, remember the SNRIs and the studies that came out really targeted kind of looking initially, besides anxiety and depression, is treatment of chronic pain. And for many of the studies, they're similar to this TCAs, whether it's a tertiary mean or secondary mean. So does he need both? Probably not. And you can eliminate one, if not both of them, depending on the progress. And so you would theoretically with Civilla treat anxiety, depression, and fibro, and may have some augmented effects to a pain response as well, if it's indicated and needed.
Do you have thoughts on as I understand it, Civilla is a little more norepinephrine involved than some of the other SNRIs, and is that acceptable? Is that risk acceptable given the rest of his history? Have thoughts on that, Todd?
Because it's phase 2, the metabolism's different. Probably you have to worry a little bit less. It may be more activating. It may give him energy and offset some of the effects of if he's, like the benzos and Neurontin that he was on, and cyclobenzaprine or the Flexeril. So it may, if anything, be kind of adding to that activation effect.
All right. Let's go to one more and see if we can. So remember our Venn diagram, and now we've got a 66-year-old female who's being treated, formerly treated with a history of ADHD, anxiety, has a longstanding abstinence from alcohol, kind of describes arthritis, but not a autoimmune arthritis. We think it's just degenerative conditions, multiple large joints, but does have a history of lumbar stenosis, limiting ability to move about, and is brought in by a daughter who is a healthcare worker because they can't really control her medication. She's been in the hospital having difficulty, and she's been prescribed bupropion, gabapentin, Adderall, clonazepam, and now has had added oxycodone, QID, along with Vistaril. The recent hospitalization was because of low back pain, inability to walk, had a big workup done, which basically shows chronic, not acute findings, but she's not taking her medication all the time as indicated, and the family members are concerned, so they bring them to us. Essentially, can you help mom's back pain? She can't walk, and what are your thoughts on the medication? So for us, what obviously the question coming to us is, now we've got a lady on oxycodone 20 milligrams a day who's got very significant cognitive changes or concerns, along with mental health issues. But what's the overriding difficulty here? Is it about one medication or one aspect of this care or another? And where do you head to from there? Stephanie, you feel like chiming in on this?
Because the ADHD part, right? That's
Well,
my
the-
preferred specialty. I love treating ADHD.
Okay. Yeah.
Yeah. So where do we start with this? So I guess what's the ultimate question? Is it regarding, so this is an outpatient, correct?
This is an outpatient. Yep. Just been in the hospital. I got this medicine. It's not going well. Mom's in trouble. We got to get her handle on this. What do we do first?
So the first question is, I mean, what is are we mostly concerned about pain, or what are we mostly concerned about? Let's see what people say. The dimension's the hardest piece of this. Yeah, so right away I'd be concerned about the confusion. Trying to go back and forth. Are we potentially looking at rapidly progressive dementia, or could this potentially be a delirium? What kind of time frame did we notice the symptoms? And what time frame was it when they came to you?
My impression was it had been a slow, gradual onset. My real impression was family members weren't happy with the legacy prescriber, and felt like they were kind of making the rounds to see what could be made better. And the back pain and stenosis was just one of the things. I think people were looking at the oxycodone. Oh, great. Now she's got oxycodone too. What do you think about that? And my impression was it really wasn't about the pain issue. It was the other stuff that was the prescient issue, because the only real hassle with the pain was it was limiting function. But obviously the function was more limited from my perspective, from a cognition and or mental health perspective. And so I didn't, I was stuck in that regard because I wasn't the one prescribing. I didn't even know, why the Adderall was there. Was the Adderall there to try to counteract cognitive changes, or?
Well, it sounds like she has that history of ADHD. So, I mean, if with this patient, I think that my primary concern would kind of be looking at the medication side effects. I mean, I would be sure the Adderall with the oxycodone plus the benzo is a concern. But when you talk about looking at this person's medication, trying to maybe start weaning off, we've got to start looking at the ones that will produce the least amount of side effects initially, or that's possibly worsening confusion. So the first thing that I would look at taking off is, do we need the Visceral right now? We have clonazepam and we have Visceral. Is it anxiety that's the problem? And if anxiety is the problem, then maybe we do need to look at the Adderall. Are we getting anxiety from the stimulant? We getting anxiety from the bupropion? Because they kind of work similarly. So really, my first impression, if I was going to start with removing a medication, would be the Visceral, because it's easy to come off. It's going to, the anticholinergic property of Visceral is going to help with the confusion. So that would be the easiest thing to remove. Patient wouldn't notice it coming off. What do you guys think would be the second thing, would be my primary concern with removing if confusion was a big issue? Yeah, what would be the second thing that you guys feel like you would want to remove? And I agree, Nicole. Too many sedating meds, absolutely. That's gonna potentially cause delirium, the confusion during the day. If she's unable to get up and move around because she's sleeping, I mean, that's gonna cause pain. Yep, Henry, I would agree. And Joyce, I would agree. Weaning clonazepam, 1 milligram TID, start removing that. Okay.
uh, comment about adding buprenorphine and reducing the clonazepam. Yeah. I did. We did move to buprenorphine really pretty quickly in this individual, not because I thought it was a big part of the problem. I just thought the oxycodone wasn't going to be useful, and this was a way to switch over. We were able to go to transdermal buprenorphine without any difficulty, direct switch. But primarily, my thoughts on that was, yeah, the opioids are a bad idea. I can help you switch, but that's not going to fix any of this problem, is it? Because if the patient's got stenosis, we could do something for that, get her walking. But to me, this push me, pull me of the clonazepam, Vistriol, plus the Adderall, and even the bupropion and gabapentin are in that. It felt like it was a ping pong match inside her brain, and that's a challenge for us in the opposite way, in that how do we communicate to the team that we need to kind of fix this problem and go in a better direction.
Yeah, and last thing to mention with the Adderall and the bupropion, first look if she truly does have a history of ADHD. Is it really concentration attention deficits, or are we just dealing with side effects from the other medications, right? And I would look at stopping one of those. And if let's pretend she does have a long-standing history of ADHD and needs the Adderall, then the bupropion would come off right away. The Adderall covers the receptors that buprenorphine would saturate, so you wouldn't get the withdrawal effects of that. So that's how I would kind of weigh back and forth between the Adderall and the bupropion.
This I include in here, in that remind ourselves that a lot of times, the limiting, medications which are limiting function, the opioids were easy to switch. It's a lot easier to switch into buprenorphine from oxycodone than it is to make these other changes that need to be made, but which are more important. So I put that in here, that I don't want to be a pain-centric discussion in every instance. So yeah.
And Joyce, you said, does she really need all that Adderall? If she truly had the history of ADHD and symptoms were severe, I would say yes. But it really would just depend on the history.
What about different agent for ADHD that was less? Any thoughts on that?
Less messy, for lack of a better word. Vyvanse is generally my preferred, because people feel that you don't have that crash, or you don't have that initial rush. Vyvanse is very slower onset, and it generally lasts about 16 hours for most people, so they don't get that crash period, which can cause them to become quite irritable and more mood symptoms. So that's my preferred if people can tolerate it, at least in adults.
And then the next question is, you'd have moved away from Vistriol before the clonazepam?
Yep, absolutely. Because she wouldn't have noticed an effect. Because you kind of got to develop rapport there before you start touching on the clonazepam, but Vistriol won't notice it. So it would be the thing that would kind of help some of that confusion if we are dealing with delirium. Obviously, benzos could worsen that too, but anticholinergics would be that easy to remove.
Yeah. Excellent. All right. Thanks, you guys.
Yeah, thanks everybody. Great to see all the comments in the chat. We're at the end of our hour here. There's a link to the evaluation survey in the chat there. Also keep an eye out for an email coming from me later this morning. I'll also include links to some of the previous sessions we've done. If you missed those, you can grab those. We'll see you in 2 weeks. Ed's doing our next talk. So look forward to seeing you all then. Oh, and Echo team, if y'all have time, we could switch over to that other link for a quick meeting.